Welcome everyone to the Ontario Caregiver Organization's webinar series. These webinars bring together caregivers and subject matter experts to explore topics of interest to caregivers. We do this to support and engage chosen family, friends, neighbors, really anyone caring for someone else. My name is Katie Muirhead and I'm going to be your moderator for today. We begin this gathering by acknowledging the Indigenous peoples of all the lands that we're on today. And while we meet in a virtual platform with people joining us from across the province, I'd like to take a moment to acknowledge the importance of the land which we each call home. The land I'm standing on today is the traditional territory of the Haudenosaunee and Anishinaabe peoples, many of whom continue to live and work here today. This territory is covered by the Upper Canada Treaties and is within the land protected by the Dish with One Spoon Wampum Agreement. Acknowledging this reminds us that our great standard of living is directly related to the resources and friendships of Indigenous peoples. As team members, we're learning about the lands from which we work, exploring how we can be meaningful allies and how we can support the recommendations from the Truth and Reconciliation Commission. We do this to reaffirm our commitment and responsibility in improving relationships between nations and to improving our understanding of local Indigenous peoples and their cultures. We invite you to take a moment to reflect on the land where you are. And if you're not familiar with that, we will be sharing an interactive map that tells you which traditional territory your city or town sits on, and you can find that at native-land.ca. Our webinar today is called Caregiving and Chronic Liver Disease, Challenges, Insights, and Support. As a caregiver of someone living with chronic liver disease, you may share many of the same emotions as your care recipient, like fear, isolation, stigma, and anger. Caregiving over a long period of time can also increase the risk of burnout, and so it's important to take care of yourself and those with chronic illness. We're joined today by two speakers to talk more about chronic liver disease and the experience of caring for someone with that. So we have Dr. Angela Cheung joining us. Dr. Cheung is an assistant professor at the University of Ottawa and an associate scientist with the Ottawa Hospital Research Institute. As a liver specialist and researcher, she's interested in treating and improving our understanding of chronic liver disease and related cancers, with a particular interest in autoimmune liver disease. She's also passionate about working closely with patients and patient advocacy groups to help improve the diagnosis and care of patients with liver disease. We also have Evelyne Chenard joining us today, and Evelyn is a retired healthcare professional who lives with her husband in Edmonton, Alberta. Evelyn has experience working as an allied healthcare professional and as a facilitator in healthcare improvement. She enjoys the outdoors, family, and takes time to smell the roses. Evelyn credits her medical background to navigating her mother's journey with cirrhosis for over 20 years and brings this experience when speaking to others about their caregiver journey. And before we get started, I'd like to turn it over to Nem Maximovich, the Senior Manager, Support and Education with the Canadian Liver Foundation.
Hello, everyone. Thank you for joining us for today's webinar. My name is Nem Maximovich. As Katie introduced, I'm the Senior Manager of Support and Education at the Canadian Liver Foundation. I would like to first thank the Ontario Caregiver Organization for this wonderful collaborative opportunity that I feel will greatly benefit those living with liver disease as well as our caregivers. I would also like to acknowledge that the CLF's national office in Markham, Ontario, is also situated upon traditional territories of the Anishinaabe peoples and the Haudenosaunee peoples covered by the Upper Canada Treaties. For those who may not be familiar with the Canadian Liver Foundation, I'd like to provide you with a rather brief overview of who we are and what we do. As you can see, the Canadian Liver Foundation was established in 1969, so well over 51 years now, and was the first organization in the world created to help people with liver disease. We are committed to promoting liver health and improving the prevention, diagnosis, and treatment of liver disease through our four core pillars: research, education, patient support, and advocacy. I will now turn it over to our first speaker, Dr. Angela Cheung, as she will guide and discuss chronic liver disease.
So I wanted to thank Nam and Katie for that fantastic introduction, and for the OCO and the CLF for this invitation to speak at this session. So I'll be speaking about chronic liver disease. Here's a short outline. So I'll be talking about the role of the liver in the body, and then moving on to discuss fibrosis and the development of cirrhosis, and then finally its complications, prevention and treatment, and then touch upon some of the resources that are available for patient and families. Next slide. So the liver has over 500 known functions. We can only test a few of these on a regular basis. So the functions that we can test include how well the liver regulates blood clotting, how well it makes proteins, and how well it excretes bile, which is the chemical that's used for fat digestion in the body. Other important functions which we can't measure as well include helping the body fight infection, as well as helping clear toxins and drugs from the body. Lastly, it's important to note that nearly all blood flows through the liver, so over 75% of the blood in the body does flow through the liver, and that'll become a little bit important about what I discuss later. Next slide. So in terms of how the liver develops cirrhosis, it can be through many different pathways or conditions, but the main thing that links all these conditions is inflammation. So these are two pictures of liver biopsies, so small samples of liver tissue. And you can see on the left, there's the normal liver, which is very sort of homogeneous looking. And then finally, all the way to cirrhosis. So any form of inflammation can cause fibrosis or scarring of the liver, which can eventually lead to cirrhosis. On average, we say that this takes about 10 years to occur. So when cirrhosis happens, you can see there are these sort of nodules within the liver. And then the bluish coloration there is the stain that shows the scarring of the liver. Next slide. So as I mentioned, liver fibrosis can be caused by many different conditions. And really it's because the liver is actually trying to heal itself, which leads to fibrosis. So any process that causes significant damage to the liver will lead to fibrosis over a period of time. I do think it's important to note that liver fibrosis is not irreversible as long as the underlying condition is treated and controlled. So we do say that liver fibrosis reversal can occur over, again, sort of 5 to 10 years. It never returns back to normal, but it is possible to sort of at least slow or even halt the progression of cirrhosis as long as the underlying condition is treated. Next slide. So there are different stages of fibrosis. So it runs the gamut from sort of stage 1 to stage 4, and we denote these stages by the letter F. So we run from F0 to 1 all the way to F4, F4 being cirrhosis. So in the earlier stages, there's a little bit of inflammation, ranging to a lot of inflammation, but no scarring initially. And then eventually, as that inflammation becomes chronic, there can be scarring that develops, which is initially just mild and then eventually a moderate, and then eventually developing into cirrhosis. Important to note too, one of the questions that patients and their families often ask me is how much of the liver is scarred. This staging system doesn't really tell us how much liver is scarred. We know by the time someone develops cirrhosis, it essentially involves the whole liver. These staging systems is sort of more representative of what's going on across the whole liver. So again, inflammation to moderate scarring throughout the whole liver, to finally cirrhosis, which is significant scarring throughout the whole liver. Next slide. So I put this up just as essentially an outline of what I'm going to be discussing over the next several slides. So one thing that's important to note is cirrhosis, just like fibrosis, is also a spectrum. So we do denote the stages of cirrhosis ranging from stage 1 to stage 4 most commonly. So the first stage is considered compensated cirrhosis, as well as the stage 2 is also considered compensated cirrhosis. And stage 3 and stage 4 is when somebody develops decompensated cirrhosis. And so those are denoted by the complications of cirrhosis. So stage 1, patients don't have ascites or varices. In stage 2, patients can have varices, which have never bled. And then by the time someone reaches stage 3 or 4, they can develop ascites or bleeding from their varices. And then finally, the overlay on top of all of that is something called hepatic encephalopathy, which I'll discuss a little bit more later, but this can occur throughout all of these stages. And the stages do associate with prognosis. In 1 year, the prognosis or the risk of mortality ranges from 1, 3 to 15 to 30%, depending on the stage. Next slide. So as I mentioned, cirrhosis can be caused by many conditions. So there is a bit of a stigma sometimes around cirrhosis, but it can be caused by many different things. Again, anything that causes chronic injury to the liver can lead to cirrhosis. So these are some of the lists of causes here. So fatty liver is the most common cause within the Western Hemisphere, or is getting to that point. So about 30% of people have fatty liver. About 1 of 10 of those people will develop advanced fibrosis or cirrhosis from fatty liver. Alcohol is also a common cause, increasing during COVID. Autoimmune conditions are rare, but those are also increasing. There's also genetic conditions, viral infections such as hepatitis B and hepatitis C, and finally heart failure. Next slide. So fibrosis, fortunately, now we have many different ways to measure this. So it can be as simple as just a blood test. And some of those blood tests are pretty standard tests that we use to measure the sort of how the liver is doing. There's more advanced liver tests as well that can be done to measure fibrosis. Finally, there's fibroscans, which could be done both using just the standard sort of ultrasound. So radiologists can now do this, and it can also be done at specific tests or clinics throughout Ontario and Canada. Most of those are liver centers or liver clinics. Liver biopsy can also be used to measure fibrosis. It's always important to note for me that fibrosis or liver function is not measured using routine ultrasound or CT or MRI. The only role for those tests are really to look for liver cancer or blood clots, which people with cirrhosis can be at increased risk of, or the development of fluid or ascites. So it's not routinely done to look to see if the liver is getting worse. Ultrasound, CT, and MRI don't have high enough resolution to really look at that. The tests we use are, again, the blood test, the fibroscan, or in some cases, liver biopsy. Next slide. So I just wanted to talk a little bit about the fibroscan because it's a relatively new technology. So you can see on this slide, that's the machine essentially that records the results and helps produce the images that are associated with the fibroscan. You can see the little probe that is used. So this probe on the diagram to the right essentially is used to then measure scarring in the liver. And so it can't hit the ribs. So that's what those little sort of oval dots are. So the ultrasound waves goes between the rib cage and then hits the liver. And the next slide sort of shows a little bit about how that works. So next slide. So the ultrasound wave is one of the waves that is delivered by the probe. And then the other wave is the mechanical shear wave. And so essentially that's what it sounds like. It actually sort of essentially hits the liver. So again, that's why it has to go between the rib cage. And so this mechanical shear wave, it travels at different rates depending on the stiffness of tissue. So if the tissue is very stiff or firm, then the wave travels quickly. And if the tissue is very soft without any significant scarring or inflammation, then the wave travels slower. So the difference between the ultrasound wave and the mechanical shear wave is then calculated, and that's what tells us whether or not the liver has a lot of scarring or not. This test doesn't have any radiation, and so it's actually been a really useful test because it's also considered non-invasive. So there's really no side effects from this test, unlike standard blood tests, which are still considered invasive, and then also liver biopsies, where a part of the liver is removed with a small needle, which it can be a good test, but is also associated with some complications sometimes. So next slide. So this is just a representation. So this is the FibroScan will then provide a number. So you can see that on the bottom where it says liver stiffness kPa. So the number essentially technically ranges from 0 to 75. Nobody really has a score of 0. Usually ranges between sort of 4 to 7 or so. And so the numbers are a little bit different depending on the condition. So it is really important to use the numbers in context. So if you, for example, look at NAFLD, which is fatty liver or non-alcoholic fatty liver disease, a number of 11 or 12 will be cirrhosis, whereas in alcohol, it will just be moderate fibrosis, and in chronic cholestatic diseases or autoimmune liver diseases, it can even mean sort of F2 or to F3. So it really depends on what the condition being measured is. But it is a very useful test. Can be a little bit falsely elevated if there's a lot of inflammation going on. So we tend not to use it in that scenario because it can be falsely elevated. Next slide. So next I want to touch upon the complications of cirrhosis. The main ones are decreased liver function, because as the tissue is scarred, each cell is not able to perform its function as adequately. The second one is portal hypertension, and this is divided into varices, ascites, and encephalopathy or confusion, which I'll touch upon in a bit. And then finally, one of the complications of cirrhosis is liver cancer or HCC or hepatocellular carcinoma. So there are different levels of risk of HCC depending on the condition that causes cirrhosis. So things like hepatitis B, fatty liver, alcohol tend to be more associated with risk of liver cancer. Fortunately for liver cancer, a lot of the times it can be curable if we find it early enough. And this is, again, one of the things that we look for on ultrasound. So ultrasounds are recommended every 6 months for people with cirrhosis, specifically to look for liver cancer, so we can find it early enough that ideally it can be treated. Next slide. So just going back to this slide, that's one of the reasons why I put this up is just to highlight again the functions that we can test. So again, blood clotting, which is measured by a blood test called INR, protein level, which is measured by albumin, and bile or bilirubin, which is also used to measure liver function. So this also relates to symptoms that people can develop as the liver function gets worse. So people can experience easy bleeding or bruising, also experience sort of more fluid retention because of lower albumin. And you can also experience yellowing of the eyes or the skin as the bilirubin increases. And then finally, just highlighting again that nearly all blood flows through the liver. So that's one of the reasons why portal hypertension occurs in the liver, which I'll discuss shortly. Next slide. So again, portal hypertension is really the consequence of when blood decreases through the liver. Because cirrhosis causes those nodules in the scar tissue, it really essentially creates a resistance to flow. So blood can't get through the liver very well. So it tries to get back through the liver to the heart in other ways. And so that includes varices, and then it also includes the side effect of ascites. And then when blood flows elsewhere and doesn't get processed by the liver, again, the liver really clears toxins from the blood because it's all blood that most of the blood of the body goes through the liver. So as you eat or take medications or supplements, that blood first goes through the liver then will metabolize it or get rid of any sort of toxins, and then it goes through the rest of the body. So when it's not able to do that, that leads to increased encephalopathy or confusions as sort of various toxins build up in the blood. Next slide. So this is a picture just to demonstrate varices and how those form. So the liver is that nodular organ on the upper left-hand side. So that's a cirrhotic liver. So again, it creates resistance to normal blood flow. And you can see through the portal vein, which is that big blue column, which is going through the middle of the diagram, that blood will go through the liver. And if it can't do that, it will take other ways to get back to the heart. So that then opens up blood vessels in the esophagus, which are always there in everybody, but they're closed normally. And so when there's increased blood flow, those open up. Blood flow can also be redirected to the spleen. And so that's what will cause the big spleen or splenomegaly that is experienced by people with cirrhosis. And finally, the last varices that are more commonly formed are ones essentially similar to hemorrhoids, so they can cause rectal varices. So importantly, these varices, if they get large enough, can bleed, again, most commonly in the esophagus or in the rectum. Next slide. And then ascites forms sort of in a similar way. So when there's resistance to flow in the liver, that means that there's increased pressure throughout other blood vessels in the body. In addition, as I mentioned, the liver is really important in creating protein for the body. And the most important one is albumin. So when there's decreased albumin essentially helps bring in fluid from the tissues and maintain it in the bloodstream. When you have decreased albumin, that sort of draw is no longer there. And so fluid can then accumulate in the abdomen or the peritoneal cavity. And so that leads to increased fluid retention in the abdomen and can also lead to increased fluid retention in the legs. Next slide. And then finally, encephalopathy. So because the blood through the liver comes from the intestine, the liver then removes any sort of toxins. So it's there as a gatekeeper to remove any toxins that really shouldn't be there or aren't good for the rest of the body. And unfortunately, when these toxins aren't removed, people can develop confusion. And we think that the microbiome probably plays a huge role in that. So those are the bacteria that live in the gut of everybody. And normally they're doing very important functions. But some of them will actually produce things that aren't great for us. And so then that can actually lead to confusion. One important thing to note is that in the past, we always thought that ammonia levels in the blood were related to the risk or degree of encephalopathy. That's not really felt to be the case anymore. So we don't really measure ammonia on a routine basis. It's really a clinical diagnosis. So if people do have difficulties with sleep, so if they're sleeping during the day and really awake during the night, which is what we call day-night reversal, or if they have clear confusion or memory difficulties, this is termed encephalopathy. Now somebody has cirrhosis. And so there are very specific treatments for that. Sometimes in these cases, ammonia can be low or sometimes it could be high. So that's the reason why we don't routinely check ammonia. Next slide. And so I just wanted to come back to this now that I've sort of touched upon sort of ascites and varices. So again, we really take those clinical symptoms and complications of cirrhosis and are able to then stage cirrhosis. So it gives us a better idea of where people are and how likely the cirrhosis is to improve. So if people are in stage 1 or stage 2, it's more likely that the cirrhosis can essentially improve and stabilize if the underlying condition is treated. Often, if people are in stage 3 and 4, we think that they're less likely to recover. It's still possible, but it really depends on how well they respond to the treatments. Next slide. And then finally, this MELD score is another way we determine both prognosis and what the next steps are in terms of treatment. So this is our way of measuring liver function. So it used to be called just the MELD score, but then it was then updated with sodium. So just measuring the level of sodium in the blood. So the MELD score essentially is a calculation that involves sodium, bilirubin, creatinine, which is a measure of kidney function, and then INR, which is the measure of blood clotting. And so if we use the MELD score, we can then have a better understanding of life expectancy over 3 months. And so less than 17 is associated with less than 2% mortality. And that's important because that relates to sort of when somebody might benefit from a liver transplant. So liver transplant, the criteria we use is the MELD score and MELD sodium score. And anybody with, generally speaking, a MELD score greater than 14 will benefit from a liver transplant. And so that's the cutoff for consideration of liver transplant. Next slide. And so it's always important to talk about how it might be possible to prevent cirrhosis or transplant, as the case may be. So there are disease-specific treatments that could be used to help either delay the progression of fibrosis or cirrhosis Or again, if somebody responds completely to those treatments, then it is possible to even essentially reverse cirrhosis and prevent people from getting worse. And then there's other things in general that can be done. So general liver protection, coffee is really the only thing that's been shown to be helpful. So 2 to 3 cups of caffeinated coffee per day. For some reason, it doesn't seem to be the same benefit with tea or other caffeinated drinks like pop. It's really something specific to the caffeine in coffee. So they note that people who drink coffee regularly seem to be at lower risk of having liver damage in the long run. There's a lot of interest in other substances like milk thistle or curcumin or turmeric. And unfortunately, these seem to work well in animal models, but studies in humans haven't really been able to replicate the benefits seen in animal models. So for my patients, a lot of people are interested in taking additional things that may help the liver. I always tell people that they're free to take them. And unfortunately, there's not a lot of evidence that shows that they're beneficial. There's a lot of research going in to seeing if there's any other agents that might be helpful, but unfortunately we don't have other supplements right now that have been shown to be beneficial. Some substances can even be harmful. So alcohol in the setting of sort of fibrosis or cirrhosis can be harmful to the liver because it's not able to process or metabolize it as well. And so there's a buildup of sort of toxins from alcohol, which then can lead to further inflammation and scarring of the liver. Other things that seem to be potentially harmful to the liver are things like CBD oil or marijuana. These are only based on animal models. We don't have a lot of data in people yet. In an animal model, some doses of CBD oil and marijuana have been shown to be harmful. So I tend to tell people to avoid it right now because we don't have that much data on it. Because if you already have liver disease, these animal models that they were using didn't have liver disease. For the most part, they were sort of healthy animals with normal livers. So it's unclear what effect these would have in somebody who already has liver damage. Another question that people often ask me is whether or not there's a specific diet for liver disease. For better or worse, there is no specific diet that we know of. It's an area of research that's of interest to me. So far, all we know is that high protein for people with cirrhosis is really important. So 1 to 1.5 grams per kilogram per day. And the reason for that is because people with cirrhosis, the liver really uses up a lot of energy. And so it can cause loss of muscle mass over time. And so it's really important to try to replace that with high protein. The other thing that's important is also weight-bearing exercises. Next slide. So in terms of the treatment specifically for the complications of cirrhosis, the main thing if somebody has cirrhosis is to avoid things like Advil, ibuprofen, or Motrin. So there's specific pain medications. The safest thing for people to take is Tylenol, 2 grams per day as needed. Certainly, we don't recommend that someone would take 2 grams every day consecutively, but that's sort of the maximum that can be needed, that can be used if needed. So the other NSAIDs are avoided, things like Advil, etc., because people with cirrhosis can be prone to kidney injury, and those drugs can also injure the kidneys. And then there's specific treatments for varices, ascites, and encephalopathy, which I'll touch upon on the next slide. And then finally, liver transplant. Next slide. So in terms of the treatments, so I'm not going to go through these in great detail, but there are treatments for each of these. So there's gastroscopy or endoscopy with or without banding, which is when elastic bands essentially are put on the varices to help shrink them. And this is really to prevent future bleeding episodes. There's also a lot of data for nadolol, propranolol, and carvedilol, which are medications which essentially can decrease blood pressure in the varices specifically, and therefore prevent bleeding that way. If somebody does not have bleeding, these can be used. If somebody has had bleeding in the past, normally we do both banding and then also add on these medications. With regards to ascites, the main treatment is to restrict salt to less than 2 grams a day. There's also diuretics that we can use, so specific medications that help people pee out fluid. And then finally, if people don't respond to either of those treatments, then paracentesis can be used, which is a procedure with a needle that removes fluid from the abdomen. And some people can need this as frequently as once a week. On average, most people may need it once a month or so. Finally, for encephalopathy, the mainstay of treatment is to avoid sedating medications. So even simple things like Gravol or Benadryl, opioids for pain, or sleep aids. These things, because the liver is not working as well and can't process medications as well, these medications can stay in people's systems when they have cirrhosis and then actually cause worsening encephalopathy. So it might actually have the sort of opposite effect. If somebody does need sleep aids, Zopiclone tends to be the safest, not really associate with liver injury. And then finally, the other mainstay of treatments are lactulose, which essentially causes diarrhea. So we aim for 3 to 4 bowel movements a day with lactulose. And the idea is essentially to get rid of any sort of toxins in the blood that way. And then finally, rifaximin, which is a non-absorbable antibiotic, again, to try to alter the gut microbiome to sort of reduce the toxins that are produced by those bacteria. Next slide. So finally, I did want to put up a slide with regards to resources. There are obviously some general resources. So the CLF is a fantastic resource. We also have our own website, which is just starting to take off. So it's still being built, but that's the Centre for Liver of Eastern Ontario, based in the Ottawa Hospital. And then there's condition-specific resources for patients and families with liver conditions. So condition-specific are Cirrhosis Care Canada, which is also a new website that's come out of Alberta. Then there's specific ones such as the Canadian PBC Society for patients with PBC, PSC Partners Seeking a Cure Canada for people with PSC, and they also have Zoom rooms, which are done monthly. So it allows people to sort of chat about what's going on. And then finally, there are a number of resources. I only have the ones here from Ontario. So these are different services and programs that can connect people as well. And so I believe that's my last slide. So I do want to thank everybody for their attention and support and care, and for everything that you do. And I'm really excited to hear about Evelyn's talk as well.
Perfect. Thank you, Dr. Cheung, for that wonderful talk. I will pass it to Evelyn for her journey or sharing her story. Evelyn?
Thank you, Nam. I'd also like to thank the Canadian Liver Foundation and the Ontario Caregiver Association for letting me share my story. So I bring awareness to the caregiver role and to liver disease. Next slide, please. So both of these roles, the caregiver and liver disease, they can be short or long-term. So the story is about my mom, who lived with liver disease, and she lived a long and good quality life. So this is Elizabeth. Mom was always there when we were young. I remember a caring mother. We were always fed nutritious food, and we were always dressed properly. We had a loving home, and she really cared for us. Next slide. So we grew up in Northern Alberta in a big French Catholic family within a close-knit community. Mom was very proud of us. Values were impressed upon us at an early age. Next. So we grew up and we moved to Edmonton, moved to the city, and we all went to college. But you know, we always came back to visit. We loved our home, and we knew Mom cared for us as any parent would. So our family had always embraced the outdoors. As children, the outdoors was our playground. Nature was part of us. And we loved the season, yes, even winter. So Mom and Dad spent many years as snowbirds, traveling to Arizona. I often visited there and remember how I spent a lot of time with her. Very special moments. Next slide, please. So then we got married and we had children. Mom was such a caring grandmother. She made each and every grandchild feel so special. Next slide, please. We have such great memories of Mom with her children. She was truly caring and she felt blessed as we all achieved our goals in life. Next. So we all remember September 11th, 9/11, right? Well, for us, it was very different. This was the day that our mom was medevaced from Northern Alberta to Edmonton after she had an upper GI bleed. This was the day we were told Mom had advanced liver disease, cirrhosis. Mom was so scared. Oh, and so were we. So this began Mom's journey. This began the stigma of having alcoholic cirrhosis, a social stigma. It would have been easier for Mom to have had cancer rather than liver cirrhosis. And this was the day our roles changed. We were the ones who began to care for Mom. And this is where my caregiver journey begins. Next slide, please. Well, it took Mom quite a few weeks to recover from her GI bleed. It had really taken a toll on her physically and mentally. But eventually she went back home. But she was never the same after that, perhaps a bit sad. But she still embraced her role as grandmother. And then the appointments began. I remember one time, or one of the first times she had her varices banded. So we were told the anesthetic was not easily cleared from her system. So I remember going into the hospital room and I was asked to dress her. So I dressed Mom just as you dress a child, and Mom was still sleeping. I placed her in the wheelchair. I pushed the wheelchair outside through the snow, and Mom still slept. I picked her up, placed her in the truck, tied her seatbelt. She still slept. When I got home, she was sleeping. I had to get a neighbor to help me to bring her into the house. And she slept for the next 6 hours. And that was a really hard day. So I had learned the hard way. So afterwards, 2 of us always went to her gastroscopy appointments. So I felt like I was part of Mom's healthcare team. So because of our healthcare background, my sister and I monitored Mom's blood work. We researched her complications, and we really tried to foresee the pathway. Next slide, please. So in between appointments, life went on. There were many conversations with Mom about her liver disease. What had she done to deserve this? Where was God in all this? Was it her episode with hepatitis as a child that left her liver damaged? Had she really drank enough to be labeled an alcoholic? I didn't think so. Most days, these conversations left me emotionally drained. But I remembered that I always confirmed that it wasn't the disease that defined who she was. It was still her mom and her grandmother. Well, Mom decided to live. She fought to live. She followed all the recommendations. She ate a healthy, salt-free, and high-protein diet, and she never missed an appointment. But neither did we. Nature was still where Mom felt best. It comforted her along her journey. And in hindsight, this would have been the time to start self-care for the caregiver. I never could have predicted how Mom's disease affected me and how caring for her made me neglect myself. Next slide. So one winter, when we thought Mom was stable, we took them to the Bahamas. And this was after Mom got clearance from her family doctor. During that trip, it didn't take long before her belly started swelling up. I knew it was ascites. So we flew them back to Canada, where she was admitted, and about 10 liters of ascites was drained. So this was the beginning of the water pills. Oh, I remember furosemide and spironolactone. Seems like there was always a change in prescriptions. So many trips to the pharmacy. Next slide. I love this picture. It shows the convoluted pathways of this disease. So Mom was now under the care of the Cirrhosis Care Clinic. This staff was so understanding, mostly nurse practitioners. They played a critical role in Mom's longevity with this disease. They gave her hope. Family support was essential, and Mom's desire to live also played a role in Mom's longevity. So Mom had regular checks for esophageal varices. She had periodic ascites drained. And one day she had encephalopathy. And that was the day we thought she had a stroke. So another prescription was started, lactulose. So as the disease progressed, Mom became anemic. So she had blood transfusions, and then she had iron infusions. She had appointments with her specialists, her family doctor, weekly blood tests, MRIs and ultrasounds. And Mom never missed any of these, and neither did we. Next slide. So Mom often stayed with me during the appointments and before and after hospital visits. During these hospital visits, even overnight, I was always there. Mom had many ambulance trips, and we stayed with her in Emerge as well. There was a fair bit of personal care by then. We had converted the dining room into her bedroom. Oh, Mom began to have that itchiness. Oh, that drove her crazy. And it was so hard to find relief. That was such a struggle for her. And then she had emergency surgery for incarcerated bowel. Oh, that was a hard time. The doctor told us her chances of survival was slim. But you know, she survived. So by then, my career had suffered. It was difficult to hold a full-time job. My health had taken a toll physically and mentally. I wasn't sleeping, and that wasn't good. I wish I could have done more self-care. It was time for a change. Next slide. So we decided to move Mom to the city, into Edmonton, into her own place, since we just couldn't do the hours of travel, especially for appointments. And Mom had mostly moved in with me. Mom had never wanted her children to do personal care, and she had never wanted to move in with us. So by now, she had learned to live with her disease, and she had on many good quality days. She had really good care at her new place. So Mom focused on her crafts, on the outdoors, on things that really mattered to her before the disease. You know, my dad had always been there, but he wasn't a caregiver. We knew it, but he knew it too. So he didn't move in with Mom. He stayed in Northern Alberta in their home. So moving Mom really took a toll on their marriage and their finances, but we knew this disease was limiting. So by this time, looking after Mom was almost a full-time job. And then COVID happened. Next slide. Oh, the isolation that came with COVID. Only 2 of us were ever allowed inside. It was so hard, especially for Dad, the siblings, and when grandkids came to visit. One day, Mom had hepatohydrothorax. We had never heard of this. We had never researched this complication. So it was little microscopic holes in her diaphragm and allowed the ascites to move into her chest cavity. So they inserted a tube in her chest to drain the fluid. I guess this was called a pleurix. Next slide. So Mom still had appointments. And then when the COVID mandates relaxed one summer, the appointments became an opportunity to take Mom out to visit nature, to spend time outdoors, to smell the flowers, to have a sense of normalcy. Next slide. It was a time to have a strawberry sundae whenever we could. It was respite from the disease and from COVID. Next slide. We brought Mom to our homes where she could still connect with the grandkids. The grandkids appreciated her so much. Next slide. So by now, Mom had been on this journey for about 20 years. The disease had progressed and it became more difficult to keep it in check. The hospital visits became more common and Mom became more tired. My oldest sister had become my partner in caregiving. She was so good in keeping organized. She kept track of the medications, pharmacy trips, the bubble pack, the equipment rentals, the oxygen, and all the appointments. We had kept the rest of the family in the loop through messenger chats and video calls. Thank goodness for Mom's iPad. Next slide. So in November 2020, when COVID in hospital was in the rampage, the care had changed and not in a good way. So Mom decided no more hospitals, and that was a turning point. That was a hard day. So her care had changed to comfort care. There would be no more blood work, no more transfusions, no more appointments. Next slide. So when a bed became available, we moved Mom into the hospice. Once in the hospice, we could all visit. Most of the grandchildren came to see her. My siblings and Dad, they were able to come in, spend a lot of time with her, to touch her, and finally to hug her. We no longer had to organize her medications. No more bubble packs. No more equipment rentals. No more appointments. And no more personal care. It was a quiet time. It was emotional. Yeah, it was hard. Next slide, please. So we all scheduled visits and stayed with Mom as much as possible. Often, just sitting in her room gave her comfort. Next slide. And just over a year ago, her journey ended. And so did my caregiving journey. Next slide. So this was the sunrise on the morning of her passing. So Mom had had a good quality life from the time she was diagnosed until her passing. She fought to live, and combined with family support and excellent medical teams, that led to a long life with liver disease. Thank you for listening to my story.
Thank you so much, Dr. Cheung and Evelyn, for joining us today. Your knowledge and expertise on the liver and your experience, Evelyn, as a caregiver has been so helpful to bring some clarity to the medical side and shed some light on what it's like to care for someone with chronic liver disease. So thank you both for joining us today. We do have some time now for questions, and we do have a few that have come up that I'm just going to go ahead and start asking. We've got about 8 minutes or so left in our talk today. Nam, if you wouldn't mind, you can go ahead and take, yeah, that'd be great. Thank you. So the first question, and this is for you, Dr. Cheung, regarding the FibroScan. There was a question on how routine would that type of test be? If you can share that with the audience, that'd be great.
Yeah, so fibrosis is something that happens slowly over time. So generally speaking, we don't recommend having it more than once a year. And for some people, if we think everything's pretty stable, sometimes it's every couple of years.
Great, thank you. And we did have a couple of questions come in around medications and other non-pharmaceutical treatments. So one was asking around and I apologize if I'm saying this wrong, glutathione help? And does caffeine from non-coffee sources help? So something like pop or soda, Coke, something along those lines.
So glutathione, there still hasn't been a big clinical trial that shows whether or not it's been helpful. There's been some small studies. And I think one of the issues is always between oral versus IV. So IV is not something that can be given easily. So unfortunately, the jury is still out on glutathione. And with regards to caffeine from non-coffee sources, so unfortunately, only coffee caffeine seems to be helpful.
Great, thank you. I wanted to ask Evelyn. Evelyn, you mentioned in your talk a bit about wishing you had started self-care earlier or starting self-care, and we hear that a lot from caregivers about really trying to find that balance around caring for the person, especially when there's a lot of medical things going on, and still carving out that space for you as a caregiver. And I'm wondering if you have any tips for our audience around, some of the self-care strategies that worked for you, and, hindsight, if there was something you would have started a little bit earlier to take care of yourself.
Well, I think, when the journey started for us, it started very quick. It was, just bang, there we go. We're off running. There was never an introduction to this. I think that more support right from the beginning. I do have siblings, and, we were always in contact, but, we never trained for this. So it would have been maybe to reach out to someone that had gone through this journey. But at the time, you just don't think about that. You just have one focus, your parent, and you do what you have to do. Thank you.
Thank you. And thank you again for sharing your personal and very touching story with everyone. I think that's, everything you shared resonates with me as a caregiver, and also our audience as caregivers as well. And you never really know when to get started, but it's so important in order to keep caring for your loved one. And there are, resources for the folks that are with us still that we'll share. And OCO has a lot of wonderful programs and services for caregivers as well, if they're looking for that peer-based support along the way. Dr. Cheung, I'm wondering if you can comment on if there's any details or resources on weight-bearing exercise, and is that recommended for someone with encephalopathy?
Yeah, so Cirrhosis Care Canada actually has some great resources. So they have exercises that are listed, and sort of exercise programs that people can try at home. And it is important for people with encephalopathy because that can affect quality of life so severely, and people might be more bedbound or not able to do as much. So it is important to keep up and be active as well.
And speaking of being active, we had another question around, I'll just read it. It says you have said that some amount of cirrhosis can be reversed to a stable state by addressing the underlying cause. So does that mean improvements like reducing body mass index, obesity, things along those lines could be significant enough to move someone back from stage 2 to stage 1?
Yeah, so it's a good question. So that's one of the mainstays of treatment for fatty liver is sort of diet and exercise and 10% weight loss over about a year. So we don't want too rapid weight loss either. And so if people are able to reduce the amount of fat in their liver, that can then in turn reduce the amount of inflammation. And the liver is one of the few organs that can regenerate in the body. And so that is what allows it to sort of reverse some of the damage. And so if somebody is able to lose that weight and control like diabetes, high blood pressure, and high cholesterol, then the liver can actually heal itself and move and reverse the stages of fibrosis.
Great, thank you. We're running low on time, but I see there's still some great questions coming in. So I'm going to try to get to these last two that were just posed before we wrap up for the day. But to detect and monitor liver cancer, which provides a better imaging or detection, a CT or an MRI?
They're both just as good as long as there's contrast and it's the proper imaging. So sometimes one needs to follow the other. So a CT might show a spot in the liver that's worrisome for cancer, and then sometimes they'll recommend an MRI and vice versa. But sometimes only one imaging test is necessary, but they're both better than ultrasound. So ultrasound will let us know that there's something new in the liver, and then somebody always needs a CT or MRI as a follow-up test.
Great, thank you. And this last question I think might be great for Evelyn and Nem. It's a question around, are there emotional coaches who specialize in this disease for patients, for families? Are there support groups that are geared towards this particular population? Is there, I know at OCO, we have one-to-one peer support programming where we might be able to connect someone with shared experience, but I don't know if the Canadian Liver Foundation has any program along those lines, or you know of anything, or Evelyn, if you've connected with any services like that.
I'll just go quickly first, but yeah, I would say the OCO is a great resource. Majority of people who reach out to the CLF, whether they're caregivers or those living with any liver disease, we try to connect them with individuals such as Evelyn, who is a strong advocate for not only liver disease itself, but for caregivers out there. And I've connected Evelyn with many individuals who were seeking support at the time, and we've got nothing but great feedback and, of course, great reviews. And of course, after her presentation and her journey, it shows how much support she can provide herself. And it's important to seek out for any additional resources out there, whether it's liver specific. I find that they're probably good regardless of whether it's a specific disease or even self-help. So having more options is probably the best, I think, approach.
Evelyn, did you have anything you wanted to add to that before we wrap up today?
Well, you know, at the time when, everything was happening, and, the first thing we have right in front of us is, our phone, and, going on Facebook, I actually did find a group, and it was based in the States, and it was for caregivers for those with liver disease. And I found it was helpful. So basically anything that you can get, embrace it. Thank you.
Wonderful. Thank you. And maybe as part of the resources we send out, we can share with folks some information about the programs and services we have at OCO as well for those that are looking.